Hello, everyone. I want to start by thanking FINUT for this opportunity that they have given me to share with experts and professionals from all over the world. We are going to be discussing maternal and children's health, and this means discussing many problems that we are dealing with. This double burden of malnutrition that affects reproductive age women intensely. We haven't been able to prevent obesity and diabetes. They keep increasing, but also we see a lot of anemia around the world. You can see the yes, we can see it. Forgive me. It was my own problem. I apologies. That was only me. So, so we were with the anemia. So the dark pink, you see that the prevalence is between 20 and almost 40%. And severe anemia is above 40% in purple. You know that about half of the anemia is due to the deficiency in iron, and 80% is due to postpartum anemia in developing countries. This also entails deficiencies in micronutrients. This is a report from a global level, and we see that 69% of reproductive age women still present a deficiency in iron, zinc, or folate. And also we see that the food that we are intaking right now is very far from what should be considered as a healthy diet. There are more ultra-processed foods damaging our health. 30% of the energy that we ingest and take in Mexico come from these types of foods, but they have a lot of energy, fats, saturated fats, added sugars, sodium, and they're very low in fiber and in micronutrients. All these products also contribute to a chronic low-grade inflammation, and this is very much related with diabetes and other conditions also. It's important to note the low intake of omega-3 and polysaturated fats. You can see in green those who ingest more than 200 milligrams per day in the shape of fish and seafood. And if we look at it from the index of EPA and DHA in terms of percentage of the total fat acids in the erythrocyte membrane, we see that the levels are extremely low. Considering this alteration of the metabolic and nutritional state, if we also add to this equation the stress, lack of sleep, etc., we are reaching a state that is not very positive for pregnancy. And we see there's a lot of inflammation, oxidative stress, and this health of the placenta is impaired or affected. And also we see that there is an increase in the number of complications, for instance, preeclampsia or gestational diabetes. And together with all this, and we have said before, we see that the growth of the fetus is also impacted. We see that the weight is low, and we see that all these processes lead to sort of a programmation for chronic diseases in the fetus. We see that the newborns are small and vulnerable. It was estimated that about a fourth of the living newborns, whether they have been born too soon, or they were SGA, or they had a low birth weight, and to have an impact on all or any of these indicators, it implies impacting the health of the fetus and the newborns. You can see here that these were the preterm newborns, and there has been no decrease. The figures are quite stable, and there has been an increase even in some areas. So now the nutritional care is very important. The it's very important to carry out counseling for pregnant women, and to talk about nutrition and maternal nutrition since teenage years should be a priority in order to improve the health of the global population when it comes to obesity and diabetes as well, and also to count on nutrition professionals. What are our goals for the pregnancy? We want a good metabolic state, we want a good weight gain, we want a healthy placenta, so to promote anti-inflammatory processes, antioxidation, and to promote also an optimal nutrition at birth that goes beyond weight. And this will also have an impact on preventing diabetes or the restriction of the intrauterine weight, etc. The state at the birth is very important. We are considering SGA and BGA, but there are other events or other aspects that could also determine the development of these newborns in the future. The index that is easy to analyze is weight versus age, but also we need to analyze the length versus age, the BMI versus age, and the cephalic perimeter versus age. And for all this, we need to make a correct metabolic and nutritional assessment. And we do not have time enough to elaborate on this. The metabolic assessment is not very clear. And the thing that we usually analyze is obesity before birth. And we also see if there is a diagnosis of gestational diabetes. But when we do take into account these elements, it's usually too late. We should start analyzing lifestyle aspects that are also connected with nutrition. So for this, we are looking for a healthy nutrition for everyone. This would be a priority for all women. All these nutritional patterns, we have the DASH diet, we have the Mediterranean diet, and many of us here are not in the Mediterranean area, but we can still make adaptations of the characteristics and base our nutrition on vegetables, fruits, grains, and use also fish and seafood in our diet, and maybe moderate the consumption of poultry, of eggs, of cheese and yogurts, and to limit processed foods and sugars. This has a lot of nutrients, and it includes a lot of antioxidant foods and substances. And we see that there might be certain changes with regards to the Mediterranean diets, but what we're looking for is for omega-3 fats. We want antioxidants, oxidants, and monounsaturated fats and vegetable proteins, etc. All this will lead to an anti-inflammatory state, antioxidative and low glucose peaks, and good health, intestinal health. Gut health. It has been documented that healthy nutrition during pregnancy is connected to lower index of gestational diabetes, lower levels of weight gain, lower levels of preeclampsia, and even lower adiposity in children as well. When it comes to the Mediterranean pattern, it promotes cell processes that will improve the oxidative balance within the placenta, and this helps to the fetal growth. And this is a meta-analysis where several clinical trials were analyzed, and we see that Mediterranean diet will lead to a lower risk of gestational diabetes and small risk of small for gestational age. And in the cohorts, we see that there are many other advantages as well. And it will also lead to better gestational age delivery. We are preventing for preterm births, and we see that in the clinical trials. We see this, and we see that there is a reduction in the preeclampsia and gestational diabetes, etc. When we talk about this, is a Cochrane revision, a systematic revision from 2017, where they assessed interventions in lifestyle, whether it included diet and exercise to prevent gestational diabetes. When it comes to diet, we do not know risk or benefit as a conclusion, but the exercise, we don't not really know if there is risk or benefit. But when we add them together, mixing those two interventions presents potential benefits. And we know that each intervention can be unique, but when we combine them, they can have an important role in the prevention of several conditions during pregnancy. So diet is very important. And secondly, something that is important is supplementation. For instance, iron and folic acid is recommended for all pregnant women, folic acid for even before pregnancy to prevent certain conditions, and also calcium, especially for women who have a low calcium intake and who are at high risk of preeclampsia. But in Cochrane 2018 included a recommendation or said that even if we went up to 1 gram per day, not even 1.5, as stated before, could contribute to lowering the risk of preeclampsia. When it comes to high-risk women, with regards to folic acid, there is this study from Canada that mentions that up until 12 week, we can use high doses of folic acid, but only to women who are at high risk. That is, for instance, previous pregnancies with neural tube defects or family connected risks, things that we can imagine, obesity or heart bypasses or alcoholism or other types of diseases could entail a moderate risk that could lead to folate deficiency. And those have a recommendation of 1 milligram per day. And with low risk, we would be considering 400 micrograms per day when there is a low risk of the neural tube defects, for instance, or folate deficiency. So this is not one size fits all. It should be adapted. But everyone, we should, in every case, we need to keep a balance between folate and B12, especially because we don't want to have too high folate level and too low B12 level. And when we talk about supplementation with different micronutrients, the WHO has updated their documents, and they have mentioned that there is a benefit to be found in supplementing with micronutrients, especially in low-income countries or vulnerable populations. This comes from 2 revisions that were very clear, meta-analysis that were very clear in their conclusions. This was carried out with more than 8 micronutrients, and we see that the benefits are enormous when it comes to preventing low birth weight and preterm pregnancies. The SMM, there's another study that adds folic acid, iron, and another micronutrient was added to see if there was an impact in the low birth weight and in fetal death. But when we included more than 4 micronutrients, there was even a greater reduction in the low weight risk. And when it comes to preterm, there was also a trend towards a reduction. Many nutrient supplementation have been studied, but also other approaches have been studied for preterm births. This is a Cochrane revision. And when it comes to the high quality of evidence deal with the supplementation with omega-3 in order to reduce the number of early preterm and preterm pregnancies. Also, zinc has good evidence to back the supplementation of zinc. There's the consensus among experts that established that we need to provide omega-3 minimum levels to reproductive age women, and to add at least 250 milligrams of DHA and EPA, and additional 100 to 200 milligrams of DHA in the case of pregnancy women. And those who have low blood concentrations, we can even go as far as to give them 600 to 1,000 milligrams per day of DHA and EPA per day. And in an update of Cochrane 2018 about supplementing with omega-3, we still see that there are positive effects on preterm pregnancies and early preterm pregnancies. It lengthens the duration of the pregnancy and also contributes to a better weight at birth. There was another systematic review of 28 trials, and we see that there is a high quality evidence that it can omega-3 can contribute to preventing preeclampsia in low-risk pregnant women. Moderate evidence about all pregnant women and low-risk women. And when it comes to cephalic perimeter, it also contributes to improve the situation of women with low risk. When it comes to the deficiency of vitamin D, we see that there is a problem here. We have sort of a controversy when it comes to the intake. Nobody tells you about the number of units that you need to take during pregnancy. There's a high variability. We have a study in Mexico where in the first quarter we saw that what we see around global data, about 37.3% in deficiency, and we saw that even when they were followed after intervention in hospital, still were in a deficient state, and only 10% received above 400 units. So 400 units do not seem to make the cut to contribute to better health. When it comes to the supplementing with vitamin D influencing birth weight, we see that there in many studies there is certain evidence of the influence of vitamin D in birth weight. So, and when it comes to preeclampsia, we have seen mixed results. Some talk about prevention, others don't, but we know that there is a greater risk of preeclampsia when there is in a deficiency of vitamin D. When it comes to supplementing with in Cochrane, they analyzed also supplementing, and there was a potential benefit. When it comes to the dose, if I make an assessment according to the dose, the effect will be clearer. So if I provide 601 units versus giving 600 units per day, tell me of a lower risk of gestational diabetes. In a recent report, we see that doses that are below 2,000 units versus placebo, there is no significant difference. But when we compare 2,000 versus 2,000 or less, there is a reduction of the risk in gestational diabetes. There is nothing conclusive. As you can see, all doses that have been studied are very different, but it looks like when it comes to 200 and 400, we would be below the necessary concentration. And when it comes to breastfeeding, the supplementation needs to be very customized, very personal. And we need to take into account that we want to promote breastfeeding, maternal breastfeeding. It is the ideal way of providing nutrients and food to newborns. It provides many benefits for the child, but also it's beneficial for the mother. It diminishes the risk of breast cancer. It contributes to weight loss. And we see this revision of 14 cohort studies. It was a systematic review, and we see that the longer the breastfeeding, the less the retention of weight was shown. When it comes to the obesity risk, we had a notable population, and we saw that there is a less risk of obesity. 105 observational and experimental studies. There was a meta-analysis that show these figures. In all subgroups, we see a protection against obesity or being overweight as adults. When it comes to the 12 months, when the children need to be incorporated to the family diet, which should not be the family diet that most of the population has, but rather nutrition of foods based on natural products. So just to finish, we need to consider that each of the pieces of the puzzle is important, and adding all these parts will contribute to promoting a healthy diet, diminishing the damage in the to the fetus. We contribute to anti-inflammatory processes. We manage to balance the energy strata. We have also because at the end of the day, maternal health and correct fetal growth are key parts to decrease the risk of illnesses in the long term in the life of the people. So my conclusions would be that we have a high prevalence of obesity, gestational diabetes, placenta diseases, and we also have a big number of small SGA children and vulnerable children. And maternal nutrition affects both the glycemia, the lipids, the oxidative stress, inflammatory state, and therefore the growth and the well-being of the fetus. It is urgent to change the quality of diet, and I think the ultra-processed foods are really key, and also to increase the quality of the nutrition. We want to have a supplementation that is personalized depending on the risk factors, the individual intake, the presence of deficiencies or not, and we need to make a correct assessment. At a clinical level, we also need to promote nutritional support in the first 1,000, 2,000 days in the life of people with accompanying professionals for these women. And for this, we need to develop good nutritional assessments, and also for lifestyle and education in order to be able to work better as a team. Thank you so much for your attention.